This is the Shift Shapers Podcast, connecting benefits advisors with thought leaders and entrepreneurs who are shaping the shifts in the industry. And now, here's your host, David Saltzman.
We talk a lot about the drivers of healthcare costs. And one of the ones that we don't often see because it doesn't float to the very top when we're looking at claims reports and whatnot, is chronic kidney disease. And yet it's a huge driver of costs. And up until recently, there wasn't a lot being done proactively. And, as an industry, we've had this conversation on the podcast. As an industry, we're really great at looking out the rearview mirror, but we're not so great at looking out the windshield. And these days, the technologies that are really helping us and the companies that are really helping us are the ones that are helping us look out the windshield. I always tell people, you ought to look out the windshield. It's way more important. That's why it's 5 times the size of the rearview mirror. So with that, we brought in an expert and an old friend, Kimberly Langford. She is an RN, and she's also the Director of Business Development at Specialty Care Management. And this is an area that Kimberly is incredibly knowledgeable on. So we thought we'd spend 20 minutes and pick her brain, and hopefully you'll pick up some tips that maybe you can use with your clients or in your practice. Welcome, Kimberly.
Hey, I'm super excited to be here. You can call me a Shift Shapers groupie. So I'm happy to be
My
here.
very first groupie. We'll have to get bowling shirts now or something, or tie-dye shirts, or whatever. So let's level set. So what is the challenge with a lot of the companies that are out there that say that they offer prevention? Why hasn't it been happening so far?
Oh, my friend, you're going to get me on a soapbox. I think it's the same problem that we're really kind of fighting in every single industry today. And that is the fact, and without being inflammatory, simply reporting, everybody wants a check. Nobody wants to work, right? So we talk about prevention, and this is why I came to specialty care management. In our industry, there's a lot of talk about prevention, and I'll tell you, I've sat across a lot of coffee tables. I've talked to literally thousands of people all over the country, and my mantra is show me. You show me. You can't, here's the thing, Dave, you cannot have the ROI or the outcomes without involving that member in the center. And you cannot motivate and empower people with an app, a text, a letter that they're not even going to read. Most of the folks that are at greatest risk for kidney disease, or even who have very late stage kidney disease, when you talk to them about helping them keep their kidneys healthy, their first response is, that doesn't apply to me. I don't have no stinking kidney disease, right? Because they've never heard of it. They're not even aware that they're at risk for it.
Is that because that for a lot of people, until you start having really significant symptoms, at which case it's later in the game, you don't really notice anything wrong?
Well, you don't. You're right. And a lot of it's kind of like, that concept of hedonic adaptation. We kind of get used to when you're cruising down the road at 80 miles an hour, it starts to feel normal. And you step back to a 55, 60 mile an hour speed limit and you feel like you're going through molasses. So a lot of the contributing causes, the major drivers for kidney disease being diabetes and hypertension, most people don't feel bad with a touch of sugar, right? Till they're in a coma. And so it's really sneaky. There's a lot of reasons for it. It's not really rooted in maleficence. There's a lot of reasons why people don't get a diagnosis even until late stage 3 or 4.
One of the things that shocked me in the pre-interview, when you and I were chatting, is that you said that at least 60% of cases that end up in dialysis might be preventable. That's a
Absolutely.
Huge number. How do you go about getting your arms around that as a practitioner?
Well, it gets me heated, quite honestly. I'll tell you, I spent a large part of my career educating members. And what I saw was you got folks with diabetes and high blood pressure. Those are the two main drivers. Diabetes is the number one driver. About 40% of the cases we see, new cases of CKD, that's the driver. Now, diabetes affects every single organ in the body. Diabetes and high blood pressure go together. It's the heart has to work a lot harder to push sugar, right? Syrup is harder to push. And so diabetes and high blood pressure, they go hand in hand. Heart disease, there's a lot of inflammation that goes with diabetes. So, and high blood pressure, when you take diabetes and high blood pressure together, that's where you get that almost 60% of cases. And, you know, I think it's so multifactorial, Dave, because we don't want to, as a clinician, and I'm not a physician, I have a lot of respect for my physician partners. Most of our members are being followed by an internist or a family practice doctor. They're not being followed by a nephrologist. Specialists of any specialty are in short supply. Nephrologists are even shorter supply. The job of the primary physician is to kind of gatekeep and make sure that those resources are available for those who need it most. So when the light bulb does finally go off in late stage 3, if they're savvy about it, right? When that light bulb goes off, their first inclination is, well, let me get them better first. But they really don't, that's not their specialty. It's not their wheelhouse. And a lot of physicians, and there have been studies that illustrate this, a lot of physicians, we don't want to give people bad news. So instead of hearing, you know what, you're headed toward diabetes and you're going to end up with all kinds of problems, liver damage, you're going to end up with kidney damage, you're going to lose your limbs, your eyesight. Instead of telling people where that you know, you're getting ready to drive off a cliff, we don't tell them that, right? Instead, they hear, oh, I've got a touch of sugar. It's no problem. I've got a medicine for you. I've got a pill. I've got a shot for you. No problem. Then they get into diabetes and they got kidney disease. There's no problem till you need dialysis. And I got a chair for you over here, right? Instead of, how about let's avoid the chair? If you've known a lot of people, when I talk to folks, people who've seen somebody on dialysis, gets their attention.
Yeah, it's pretty miserable.
It's a hard way to live your life.
Yeah, absolutely. So,
and I'll tell you, even last night, I was talking to somebody, a friend, and I have lots of conversations. People always tell me if my kidneys fail, I'll not go on dialysis. I'll die first. And yet every single person who's told me that has gone on dialysis.
So when you start looking for the cohort in a given set of claims where you want to intervene early, are those the two markers that you look for? And do you look for one, the other, or is it seeing both diabetes and hypertension? Or can primary care physicians start earlier and just watch sugar numbers and say, you know, we need to get a nephrologist involved earlier rather than later when it's ESRD?
Well, the pathophysiology there is kind of tricky. Now, it's not as tricky as cancer, right? But it is kind of tricky. So usually if somebody only has diabetes, I'll tell you, focusing on controlling diabetes is probably the number one thing that everybody should be doing, all employers. If you see diabetes in your groups, chances are you have kidney disease and don't know it. But I typically get excited when I see, 2 or 3 comorbids together. That's when I get excited. And the main thing that we're going to look for is their GFR. What's the trend in their GFR? A GFR stands for glomerular filtration rate. It's a fun word to throw
Easy
around
for you
parties.
to say.
Makes you sound, yeah. GFR. Basically, it's a test that, in very simple terms, it just tells you how fast the filters in your kidneys are filtering. Just like I often use, if I'm talking to a truck driver, I'll talk about his fuel filter, right? Or a Brita, if you've got a water filter. When that filter's new, it filters really fast. And as it gets older, damaged, it slows down. So watching what it's doing over time is more important to me than what is it right now. Because somebody could have a GFR of 100 and have a perfect kidney function, not have any issues at all. Somebody else could have a GFR of 100 and have stage 1 kidney disease. I want to know what's it doing over time, and are they spilling any protein in their urine? So proteinuria or albuminuria, which albumin is basically a little baby form of protein. Very simple terms, but this is a big molecule. We shouldn't see it passing through those filters. Just like if I filter water in my kitchen, my Brita filter, I shouldn't see sand and grit in my water, right? So it's the same kind of concept. So I primarily look for those two things, but if you have 2 or 3 of these comorbids, there's a whole lot of conditions that can predispose or cause that damage to the kidneys.
So I guess, it isn't usually sudden onset CKD. So, why is it always such a surprise? And how do we get past that?
Yeah. I think education. But there's a lot of reasons for why it's tricky. So for instance, and I challenge everybody usually when I'm talking to folks, I challenge you, Dave, go home and get a copy of your labs and tell me what your GFR is. See if you can find it. GFR is hard to find. You're going to find it on a metabolic panel. It's not a special lab, but sometimes it's written GFR, sometimes it's written eGFR, sometimes it's glom fill rate, and you'll see a bunch of numbers on there. You'll see it for AA and non-AA, and that's changing right now. The National Kidney Foundation, who in my professional and personal opinion is the leading authority on kidney disease and clinical guidelines for that. But basically that's the GFR. And most labs, many labs across the country, aren't even going to give you a number for it until it drops under 60. And it's not that they're trying to be mysterious. Well, I'll get into that in a minute, but that would be like, do you remember back in school? If you took a test and you got it back and it said, hey, you didn't get a D. It tells you nothing, right? So sometimes the light bulb goes off for people after talking with us and they call their doctor's office and they say, hey, what's my GFR? And the little MA in the office looks and she sees the greater than 60 sign. She says, oh, it's normal. And the member pats themselves on the back and smile and they know absolutely nothing. All they know is that they're not failing yet. Right? So, and there's a lot of reasons for that. Like I said, sometimes that GFR, that filtration rate can decline because we're getting older. That has nothing to do with kidney disease. It's supposed to get old. It's supposed to slow down a little bit. If you're a muscly guy and you're preparing for like a big weightlifting thing or triathlete or something, creatinine, the GFR is largely derived from creatinine. Because it's a byproduct of muscle metabolism and it passes through the kidneys largely unchanged. So that's why we use it to determine the GFR. So sometimes people can have a weird little dip because of creatinine. They burn a lot of muscle, has nothing to do with kidney disease. So the problem is that no alarms go off until it drops under 60. But if you're 90 and then you're 80, and then you're 70 and you're 61, it's still a big drop, but no alarms are going to go off until it drops under 60.
So if a company engages a firm like yours, what's the first thing you do? You take a data dump, hope that it's a claims dump, hope that it's clean, and then you look for those comorbidities? Is that kind of how you start focusing in on the patients with whom you need to engage?
Right, so it's really customized. Like our strategy at Specialty Care Management, we have a pretty narrow niche. So we want to look for risk wherever it lies, whether that's cancer or dialysis or kidney disease. And so we do follow some codes. So sometimes people say, I only want you to go after the folks that already have a diagnosis of kidney disease. And then we'll just look at those folks with those codes for kidney disease. If they want to do a more aggressive dive, such that, let's find who probably has kidney disease that doesn't have a diagnosis yet. That's that emerging risk that we talk about. Then we'll look at more codes to help identify where are those people that, may have a kidney disease diagnosis that don't know it yet. Yeah.
Claims-wise, why do you think this is something that generally has been under the radar for employers or even for advisors who are knowledgeable in looking at claims reports?
Because they're looking for diagnoses of kidney disease. And again, there's no problem till you need dialysis, right? I'm not getting hit with dialysis claims. I don't see dialysis, right? And yet, every time a member advances in a stage of CKD, whether it's diagnosed or not, You can have kidney disease and not have it. I mean, I've worked with people with GFRs down in the 17s. So a GFR 17, 2 points away from ESRD, it's low enough to go on a transplant list, and they don't have a diagnosis.
Wow.
That's off. I can tell you some stories.
I'm sure that you can. I'm sure you can. I mean, I guess this represents a significant amount of spend if you can get ahead of it. What is the cost, an average cost for a patient once they have a diagnosis? If there is such a thing.
Oh my gosh. Yeah, so we know, and I'm just pulling up because there were some great stats, if I can find them here. So with here's and this is commercial groups versus Medicare groups. This is really telling. So as I said before, every time a member advances in stage, their costs go up by 57%.
Wow.
So for commercial groups, for members who tend not to have any kidney disease, their cost is about $7,500. Once they advance through those stages and they end up, say, CKD stage 4 or 5, instead of $7,500, they go to almost $77,000. And when they hit ESRD, obviously those claims jump from almost $77,000 upwards of $122,000. And once people go on to dialysis, then those costs, Craig's talked about those before, but the average billed charge we see in the U.S. is around $830,000. Medicare groups, on the other hand, their costs for ESRD is $87,000. So obviously your commercial groups are paying the brunt of that, but you can definitely see that jump in stage. It's significant. And a lot of times they'll jump in that. You'll see that costs are going up, but usually it's because these folks have a lot of other comorbids.
Sure.
They have a lot of other conditions. So it's easy to say, well, yeah, they're more expensive, and that's because, they were in the hospital with CHF, congestive heart failure. And it's not in our faces yet.
So, if one might ask, if a member's already being case managed, why add yet another service? How does that integrate? What's the imperative there?
It's a specialty, right? So not every, and nurses are fantastic, but you can't know everything about everything. My colleague here, Cheryl Riley, who heads our cancer management program, it's a very similar program geared on, obviously reducing costs and risks associated with cancer. She lives and breathes cancer like I live and breathe kidneys. She knows things I don't know. I could not. I know enough to get around. I know enough Spanish that I could ask you if you have pain, but don't ask me to do any complex teaching, right? It's the same kind of thing. Mm-hmm. So case management is not case management. Sometimes case managers are more medical managers. Sometimes I describe it like they're concierge medical shoppers. How can I get you the best bargain? How can I send you to the right place? This isn't that kind of a program, right? The program is we specialize in the nuances of kidney disease and understanding, what's the significance of making sure that this member is on an ACE or an ARB. Why do I not want them to be dehydrated when they're on one? That's a significant one. If a normal GFR of a 99 is good, then why don't I want to have a party when it's 136? How is that not better? So that's not their specialty. They have a specialty. A generalist cannot do the job of a specialist, right? Craig often talks about, our president here, he often talks about the difference between your general surgeon and a thoracic surgeon. If you're going to have open heart surgery, your general surgeon could probably, do some surgery, right? But you don't want him doing your bypass. Does that make sense?
Sure. So we've got about a minute left. If I'm an advisor, if I'm a benefit advisor and I'm talking to clients about claims in general, as more advisors are today, as we see a resurgence of partially self-funded groups, especially across a wider segment of the market, what's my conversation like? What are the couple of points I need to know as an advisor to have an intelligent conversation with a client about the impact of all of this?
Well, I would say first and foremost, very easy, quick win is if you see diabetes in your group, and especially if you see poorly managed diabetes in your groups, you have kidney disease. You just might not be seeing diagnoses for kidney disease. And that's where, honestly, if I had one silver bullet that would have the biggest impact for brokers, advisors, consultants, who in my mind are the clinicians, they're the clinicians for their groups, that's it.
And that's a great place to end our conversation for today. Kimberly Langford, Director of Business Development at Specialty Care Management and official Shift Shapers podcast groupie #1. Thank you so much for spending time and sharing your expertise, Kimberly. We appreciate it.